Very interesting. Let me now go back to this concept of the multidisciplinary approach, but as it applies to advanced disease. Lori, what are the barriers that your team has in advanced disease and that you've encountered?
In terms of the multidisciplinary approach, I think one of the biggest challenges is that these patients really do require a village for their care, and just the level of coordination involved with that is challenging. And then, I have to admit that even though I really love advanced thyroid cancer, I don't know everything that my endocrinology colleagues know about thyroid cancer in general, and also about the associated syndromes. And so when I rule out a patient for a pheochromocytoma, I have to look it up to make sure that I'm ordering the right tests. I think it's much better when I work with my endocrinology colleagues. And actually, that's one of the really great things about this disease. When we think about a multidisciplinary clinic in oncology, we think about the medical oncologist, the surgical oncologist, and the radiation oncologist. And with thyroid cancer, that team also includes endocrinologists. And then because we're talking about this part of the body, we also think about the speech and language pathologists, our nutritionists, and all of those other folks who are really an important part of the multidisciplinary clinic.
Mike, I'd like to get your take on that as an endocrinologist.
Yeah, one of the challenges is being part of a multidisciplinary team that's not always in my building. When I work with my team at Memorial, it's pretty easy. We always have each other's phone numbers. I know what days Eric is in clinic. I can dial down there. But many times I'm asked to participate in the care of patients that only see me, but they see a surgeon somewhere else and a radiation oncologist somewhere else. And that's a real challenge. Even if they're very, very good people, even folks that Steve and I share back together that go to MD Anderson and Memorial, we have a shared treatment philosophy, but I don't always have access to all the scans, all the pictures, all the discussion. So even when you're dealing with experts in different places, it's that communication, it's having the availability of the data in a real-time way that really makes this work. And so I think it's a real challenge in the community to pull this off. Even if you're an expert medullary, you put me out in the community by myself, I'm going to have a really difficult time doing this, even though I can email all you guys. So I think a lot of these medullaries, unless they're really simple and cured, probably do benefit from going to a regional place where they have some semblance of a multidisciplinary team.
Well, this has been a really excellent and high-level discussion, and I've appreciated everyone's input and thoughts in the management of medullary thyroid cancer throughout the entire spectrum of the disease. Let me leave with some final thoughts and ask you, let's start with you, Steve. Any final thoughts on this issue?
Well, I think this is really a prototype disease in oncology because we have a tremendous amount of knowledge and growing about the role of genetics in this disease and the ability to target those genetics progressively with therapy. So I think we're really a poster child actually for the use of targeted therapy as well as genetic management of patients with inherited syndromes.
Thanks, Steve. Lori, what do you think?
Well, I guess just to build on Steve's comment, it really is truly remarkable the kind of progress that has been made because of what we know about the molecular drivers of this disease. Especially when you take into account the rarity of the tumor. And the fact that there are now 2 drugs that have been FDA approved for the treatment of medullary thyroid carcinoma really is a remarkable feat. And I think that the research community, the pharmaceutical industry that has taken on this challenge, as well as the patients who really have made great sacrifices to be involved in the clinical research, need to be applauded and congratulated on the kind of progress that we've made. And I don't think that we're going to be stopping that progress anytime soon.
Eric?
Yeah, I think this is like an extremely exciting era for a certain disease that, there's always that quintessential target that we have, but there's other targets like RAS that's just coming out, that there are new drugs that are really have activity. And the most amazing thing is that people are willing to study it. And, there was an era when it wasn't being done. And, I think what we're learning from this cancer is really quite amazing. And it's a very different field now than it was a decade ago.
Mike?
Yeah, I think one of the real critical things that I think about a lot is, so what's the natural history of this disease? So that we set up realistic expectations on day one. we generally know who we're going to cure and who we're not going to cure. We don't always know who's going to do bad, but we can set very realistic expectations up front, right when we're doing the initial therapy, and explain to the patient that those risk estimates are going to change over time. We're going to have to follow the calcitonin. We're going to have to do the CEA. Many times I tell these patients, you're going to have to ask me again in a year. How am I going to do? Give me a year under my belt. So I think as all of that leads into who we select for the targeted therapy, helping these patients that may look like terrible distant metastasis know that many times they're going to put along for a long time. And if they're not, we're going to sort that out in the first year or two. So I think understanding the natural history of this disease allows us to know when we need to intervene, when do we watch, what's the role of genetic testing, and helps us put that whole 360 management together for an individual patient.
Well, this has really been an excellent discussion today. I want to thank each and every one of you for your input and your thoughts and comments. I think and I hope that the audience has enjoyed this today and gotten a lot of tips on how to manage medullary thyroid cancer. Thank you very much.